The following podcast is part of a certified educational activity titled The Power of Personalized Approaches in Advanced CCA, Team-Based Strategies to Individualize Clinical Care. Access the entire activity and complete the post-test at peerview.com/NJR860. Downloadable slides and practice aids are also available.
Hello, I'm Professor Constanze Döhner from the University Hospital of Ulm in Germany. Welcome to this educational program on the personalized management of IDH1-Mutated AML. And I'm also very pleased to welcome my colleagues, Dr. Stéphane de Botton from Institut Gustave Roussy in Villejuif and Dr. Chael Roberts from the Weill Cornell Medical College, New York, to this discussion. Throughout the program, we will follow a case of an older patient with AML and provide guidance on topics ranging from appropriate mutation testing to treatment selection and safety management. We've collected material from this discussion, including guideline recommendations from the European Leukemia Net, and made it available as downloadable resource, so you may want to access this practice aid now. So what are the goals for today? During this discussion, you will learn that guidelines consistently support the use of modern genomic testing to capture diagnostic, prognostic, and therapeutically relevant information. Personalized care in AML is informed by actionable, targetable mutations such as IDH1 mutation, alongside other baseline assessment and fitness or lack of fitness for intensive therapy. And you will learn about the use of IDH inhibitor regimens, which is supported by long-term evidence and can be facilitated by attention to dosing and safety considerations. So we would like to start today with a case, an older male patient with acute myeloid leukemia and comorbid illness. So this is Bertrand, a 76-year-old male with progressive fatigue, easy breathing, and mild exertional dyspnea over the past month. So additional findings have been made with 2 recent episodes of epistaxis, low-grade fevers. The patient has a chronic kidney disease and anemia, and the performance status was 2. So what we would like to discuss with the next minutes is, while we waiting for the molecular results, for the results from next generation sequencing, we can determine if this patient is fit for intensive induction versus lower intensity treatment. Is there any new evidence that can help us to guide that determination? So I would like to ask Stéphane.
Thank you, Connie. I think that it's quite easy to answer to start. 76 years is probably too late, with the exception of very, very fit patients and favorable genetics. Otherwise, they're unfit for intensive treatment. So age by itself can be generally considered as a contraindications to use intensive chemotherapy, because early death rates are very high, and we'll see that later in the presentation, that's the thing that we should consider even with lower intensity. So age by itself is a problem.
I do agree. I think there was a very nice paper published by Venditti and colleagues in Blood 2025, and they are absolutely aligned. This recommendation is absolutely aligned with what you have said. So age alone is no longer considered as an indicator in determining which patient should be defined as fit or unfit for intensive treatment. And instead, we should assess fitness and monitor carefully, but not assume fertility. And ELN 2022 recommendations, they explicitly omit the definition of fitness, and the decision should be made whether a patient is fit or unfit. Unfit is multifactorial and therefore should be made more or less on an individual basis.
Yeah, we'll see probably some slides from the Adriano Venditti and the VIALE-A study showing that age in itself is not a problem for non-intensive treatments, but comorbidity score is crucial in that case. And here on the slide and personal recordings of the patients, we have things that should be taken into account: renal failure and PS and fever, which has been associated with early death in many studies with lower intensity, especially at that age range. Geriatric assessment is something that can be done by every doctor, not specialist. It's rather easy to do, but it takes time. So you have to observe the patient, ask questions, and so on. Otherwise, all these informations are really important. Maybe in that case, cryopreservation of oocytes and sperm is not a question, but generally speaking, indeed, you need to have lots of information that takes time to have all together. So again, you may wait 2 or 3 days prior to treating the patient. So everything will help us to have a more precise description of what you may anticipate in terms of immediate tolerance, but also outcomes.
I would jump in that for a baseline assessment, I like to advise colleagues that they get very top of mind HLA typing. And you can see it says eligibility assessment for allogeneic stem cell transplant. That is very rarely being done at the moment of diagnosis. Somebody is tired and exhausted in the middle of the diagnostic testing. But I like to have people think about it that in past days, the intensive versus non-intensive discussion and thinking used to go right along with an immediate assessment of whether the patient would be under consideration for allotransplant in the future. And that thinking needs to stop now that we are very successfully taking patients who have lower intensity inductions, and irrespective of age at the moment, just to remind people that they're not making a decision right at the out of the gate that, well, never mind a transplant. I do agree with you that you're not going to be banking eggs and sperm on a 76-year-old, probably, although these days, who knows. But I do think that HLA typing should be top of mind, even for patients who are being contemplated for lower intensity induction. And of course, you don't require that to begin therapy on the patient, but it should not be forgotten. And once the treatment begins, I find that somehow that gets lost. And then a month later, when the patient looks great and is in remission and is perhaps 70 or 71 years old, having been given a lower intensity induction, and all of a sudden, perhaps you are thinking about a transplant, you don't want to be late and doing HLA typing then and wasting a month.
Yeah, the next slide showed us that age in itself do not impact the response rate and, generally speaking, median overall survival in elderly patients treated with Veneza. It's quite good again, and even above 85. But frailty T should be taken into account, and the SORA score was quite adapted for early death. So you should take that into consideration. Generally speaking, age in itself is not a problem. The main problem with Veneza, with age, is to reduce the exposure of VEN, as ELN recommended in consolidation courses. Otherwise, it's too toxic and it's associated with more death. There is a recent publication showing that if you do more than 14 days, you have more chance to have death in CR in that case. So that's important to notice. And furthermore, you can delay the interval of each cycle above 5 weeks without any trouble in terms of overall survival. So for that elderly population, 2 things are important: to reduce the duration of VEN, less than 28 days or 21 days in subsequent cycles for those who achieve complete remission, and also to postpone the next cycle about 5 weeks, which is not detrimental. So in general, they fared well.
So we would like to continue the discussion on our case, and additional testing shows the presence of an IDH1 mutation in this patient. And the question now um, uh, is it a well-established practice to order comprehensive myeloid NGS panel at the time of diagnosis? And what are the challenges of NGS in rural resource-limited clinics? And what is the issue with regard to turnaround time? We discussed this before, but maybe we should have a brief discussion again on that. And what are the implications of this IDH1-mutated mutation with regard to prognosis for the patient? So, Stefan, what is your opinion with regard to a rapid molecular screening using NGS, or are there other possibilities? And how do smaller centers deal with this issue?
So it depends on the flows of samples you do have. We tend to centralize samples to have rapid assessment, as you're doing in Germany, which is, I think, very, very efficient, because in 72 hours, you may have the results. So otherwise, obviously, digital PCR can be helpful for IDH specifically, with very quick results. So I think you must wait for these results, at least in the elderly patients. In the younger patients, it's not required now, maybe in the next future based on the OVEN trial. Otherwise, nowadays, it's not a major prognostic factor because you don't have access to anti-IDH1 inhibitors. For elderly population, it's a major consideration to have.
No, I agree. I think for these markers, we do have other techniques than NGS in our hands that are much more rapidly and even much more cheaper. And I like the way how it is performed in Europe in many, many labs, that we have reference laboratories, and you can send the sample to the reference laboratory, and these are doing the molecular screening in a very fast turnaround time. So I think that would be a good solution for centers that do not have access to these rapid diagnostics. But let's talk
Exactly.
about a little bit the prognosis of IDH1-mutated AML, and I think there are discrepant data available.
The availability of targeted treatments with excellent results has massively changed and sort of elevated the way that we look at what is objectively a rare mutation. So on the one hand, this is rare, in the sort of 7 to 10% range overall. Here you can see on the slide that there's an increasing prevalence with age, and yet you want to identify it because there are clear treatment strategy implications of the identification of both IDH1 and IDH2 mutations. And I think that's what goes along with what we were saying before, which is the quick and efficient identification of this group. I think that the prognostic implication definitely depends on other factors, including co-mutations, et cetera. But it is currently the case that in an older patient for whom lower intensity backbone therapy is considered, the standard of care for an IDH1 mutation would not be Veneza, which is the predominant regimen throughout the world at the moment. So it is quite important to identify the IDH1 patients, because there is an alternative HMA plus IDH1 inhibitor therapy that would be considered standard of care, as well as with some improved safety features over Veneza. So that's something that is top of mind for oncologists who have gotten used to Veneza as the broad standard of care.
So maybe we can switch to the next slide and come back to the diagnostics again. So I think there are clear recommendations and guidelines in Europe and also in US how to perform the molecular or the diagnostic workup in these patients. Gail, would you like to mention something on these ELN recommendations and also the ACCME recommendations that are available?
Yes, I think that the primary message is that it is an antiquated view to say that molecular diagnostics would be applicable only for younger patients with curative intent. So that was the biggest change, I would say, in the last many years, that, well, you don't have to fuss so much with older patients because there's not curative intent. It is absolutely standard of care to have a broad genetic analysis in AML for all patients, and in particular the specific categories of APL, obviously being in a class by itself, but APL and then FLT3, IDH, NPM1. These are specific categories that are standard of care that must be available for diagnosis. If it is absolutely impossible to get, then there are some microscopic and pathologic findings that can be suggestive of molecular features, but that really is not standard of care.
Yeah. And I think it's nicely aligned. I think that the recommendations, independent if they are in Europe, if they are in Europe or in US, I think they are more or less telling us the same how we should perform molecular diagnostics in our patients. Or do you see there any significant differences between US and the European Leukemia Net?
No, I don't. And I think that the message also to everyone has been so clear that prognostic risk stratification is dependent on the availability of therapy, right? The things that were the worst are now no longer the worst. So APL was the worst, and then we have good therapy, and now it's highly curable. FLT3 was horrible, and now we have good therapy, and now we are curing more. So I think the flexibility in thinking is not to look at you can't be 3 years behind in looking at prognostic risk stratification. The therapy is changing rapidly, and the prognostic groups are changing along with the therapy. And I don't think there are major differences in this. I think that it is very, I said this once and I'll repeat it, that you've got to talk though carefully with your own pathologist about how it's set up in the lab that you're working with. What is the nature of the information that you're going to get back, and when are you going to get it? Makes life a lot easier in treatment.
Yeah, coming back to our patient now, talking about the different treatment options, in particular in the case of Bertrand now with the confirmed IDH1 mutation. So what we should discuss is what is the evidence supporting Ven-Aza or Ivo-Aza in this patient. And I would like to discuss this with Stefan. And when selecting either option, which baseline factors are most relevant for choosing a Ven-based or an IDH inhibitor-based approach? Stefan.
So here it's more complicated if you have co-occurrence of IDH1 and PM1, for instance, but here it's not a question. Here, two things should be taken into account: the relative frailty of the patient, and because he had fevers again, renal failure, which may worsen during the next 2 weeks of the treatment. We've seen that very often. And the PS at 2, that could be worse. And you should take that into account strongly with a treatment that could be less toxic, especially the combination of Ivo-Aza was less toxic than HMA alone in terms of infections. Because those who are responding to the combination, Ivo-Aza, had a quick increase in neutrophils during the first 10 days, and they are protected from infections. So it's a strong advantage of having such a type of combination, besides the response rates too. So two things: frailty, quickness of response for responders with the combo, and in the end, whatever you select between the two, a better response rate. So I would prefer to have Ivo-Aza in that circumstances. In the US, it has been very quickly approved because the phase 1 study with IDH1 IVO started in 2014, so 4 years after the treatment was approved in relapse refractory AML. In newly diagnosed AML above 75 or with comorbidities, in combination with 5-ASA in 22, and more recently in the MDS with IDH1 mutations, relapse refractory MDS. So the other one, which is not available in Europe, is olutasidenib, which has been approved in 22. So both are equivalent. In Europe, only the combination based on a randomized double-blind phase 3 trial, AGILE, is approved for newly diagnosed AML, non-eligible for intensive induction. And according to countries, there are also some restrictions for those who are not susceptible to have infections.
Yeah, and I think this has consequences on the recommendations coming from the European Leukemia Net as well as from the NCCN. And I think this is nicely summarized on this slide. And the ELN recommendations, in particular, the 2024 for patients, the recommendations from 2024 published in Blood, they clearly state that if a patient has an IDH1 mutation, the recommendation is to treat him with ASA and ivosidenib or an IDH inhibitor, in this case, ivosidenib. Yeah, maybe we can discuss a little bit the data that led to the approval of this combination, ASA-IVO, by EMA and FDA. And Stefan, maybe you can maybe you can comment a little bit on this on the data that are shown on the next slides.
So the next slide is the VIALE-A, which is an all-comer study not dedicated to IDH in particular. The very interesting thing is that with IDH2, at least the 140, which is located in the mitochondria membrane, very interestingly, there is an exquisite sensitivity to venetoclax, even alone. You may have TLS with ven alone in case of IDH2-140Q. And the outcome is incredibly good. And in the ELN classification also take into account IDH2 as a very good target for ven. For IDH1, the first analysis showed that the experimental arm had the better overall survival, 15.2 months, and it's probably less, more recently published, but the control arm is really hopeful with only 11 patients, and the median overall survival was 2.2 months, even worse than TP53, so it's difficult to analyze that all-comers situation. So I wouldn't say anything except that IDH2 is very sensitive to Ven-Aza. The AGILE trial was interesting because it's a double-blind randomized trial, and with a median follow-up, large median follow-up, the median overall survival of the experimental arm, IVO-ASA, was almost 13 months. And the control arm, placebo plus 5-ASA, was 8 months, exactly what has been anticipated when we have done the assumptions of the statistics for the study. It was based on a randomized English study made by Charlie Craddock years ago. And it clearly replicates what's happening in the control arm. And you triple very easily or quadruple the overall survival, which is impressive, with 41% of patients still alive at 36 months. All these patients are 75 or above, so most are afraid, and the outcome is excellent. So hematologic recovery was faster, more durable, and conversion to transfusion independence, as you may expect in case of response, were more common in IVO than in placebo. But it was an elegant solution for those patients.
I think this is really very impressive data, and about 40% of the patients were still alive after 3 years. more or less unprecedented an unprecedented survival curve in this older population. And as you mentioned, the median age was quite high in this in the Agile study.
Yeah, that's really very impressive. And the previous slide, we've seen what you could have roughly the same outcome for 140Q, IDH1-Mutated with VIALE-A. So the period is very interesting because nowadays, even if they are older and even above 80, you may expect of a quite good overall survival in that age range. But it seems that nowadays there are lots of real life study confirming that first the safety is better with IVO-AZA, and the response rate is significantly better in that study, or could be slightly better, I don't know. But again, it's much more well tolerated, easy to use, possibly improve CR, time to CR in responders for sure, and OS and EFS could be better. So we must interpret these results with caution.
Yeah, as always with this retrospective data, it's a very heterogeneous patient population with regard to many aspects. But I think it is more or less confirming. But now we have made the decision to treat our patient with IVO-AZA, and I think we also should discuss some practical considerations and what are the general dosing and safety principles, and what we have to consider when using IVO-AZA, what monitoring should be in place with regard to QTc and interval prolongation, differentiation syndrome, and other potential adverse events. And maybe we can move on to the next slide. And Gail, are there any important issues regarding dosing when you use an IDH inhibitor in combination with IVO in IDH1-mutated patients?
I think it's been very clear that from a myelosuppression perspective, the combination of IVO with AZA in these patients is highly favorable compared to VIALE-HMA. So that is, not only is there less in the way of severe myelosuppression, but there's also the rapid recovery of neutrophils that Stefan had mentioned before. So these are advantages. However, docs do need to look out for differentiation syndrome, which is, there's actually a very cool article, one of the How I Treat theories. Blood had in the last year a particularly good How I Treat theories in AML, including a differentiation article, which the audience may want to take a look at because it's quite detailed. But the bottom line is that we had to learn, as with APL, that if you have a rapid escalation of the white blood cell count, that is not rapidly progressive leukemia. So the mistake that is to be avoided is to switch away from the therapy thinking that it is progressive leukemia, which is likely not the case. And also to be careful about using things like Hydrea or steroids to manage this rather than to dump the differentiating agent, which of course is what we need in order to get into remission. So it's beyond the scope of our current discussion to have a comprehensive discussion of differentiation, but it is terribly important to drum into everyone's mind that this, you're not, if you have a rapidly escalating white blood cell count on an IDH inhibitor, that should not be misinterpreted as rapidly progressive leukemia, and you shouldn't be dumping the therapy and all of a sudden switching to a different course. There are also a couple of meal-related things that are important for the IDH inhibitors. I always giggle that most AML patients aren't necessarily super hungry and having high-fat meals in the middle of their therapy. Much of the time, I think we're trying to persuade patients to eat rather than taking away their McDonald's cheeseburgers while they're having therapy, but still to have a look and avoid high-fat meals with the IVO. And also there are meal restrictions at least an hour before or 2 hours after for the Aluta. Alutinib is available in the United States. We had discussed it's not yet routinely available in Europe. QT interval prolongation with IVO is to be looked at. I haven't found this myself to be a huge clinical problem, but it is listed, of course, as one of the toxicities to monitor. And there are plenty of other simultaneous QT prolonging agents that are potentially used for these patients, which include all kinds of other drugs that they may be on, whether it's antiemetics or whether it's other antibiotics or heart medications, et cetera. So in general, watching QT intervals is important, and using the correct corrections. So the Bazette correction of the QT is important throughout all of oncology and AML management, so that we're not inappropriately dropping drugs for a QT interval prolongation, which is artifactual on the page rather than clinically relevant.
Yeah, I think in general, the overall safety profile was very good in the Agile study. And you already mentioned QT prolongation, leukocytosis, and differential syndrome. I think, is there anything else that was, in your opinion, an issue when treating the patients?
No, actually not. I would say the opposite, that it was quite pleasantly tolerable. We often see in lectures and so forth, everything is somehow listed as tolerable, and I think we roll our eyes sometimes when we see that. But this is actually well tolerated, with the caveat of watching carefully for these particular toxicities, and with the specific mention of not dumping a regimen that is working for the misunderstanding that it's rapidly progressive leukemia when the white count goes up. That's a mistake that should be avoided.
And are there any differences with regard to the other IDH inhibitor, olutasidenib? What is your opinion on that?
No, I mean, I would say that not major ones. I mean, I think the discontinuation rates were low. The DS is overall low. I think that in general, I think if you keep the principles in mind that we just discussed, you're good to go.
Yeah, I think the hepatotoxicity profile is a little bit different with olutasidenib, but yeah, as you said, I mean,
That's fair. I mean, the rates of LFT abnormalities are different. That is true. I have to say that I have not personally yet had to stop anyone for that reason, but you're right to note it.
So finally, we should also consider other options that are on the horizon, and we should briefly discuss this in patients with IDH1 mutation. So maybe we move on to the next slide, and let's talk about future directions. What about triplet combinations, combining ivosidenib, venetoclax, and isacitidine in these IDH mutated AML patients? And I would like to hear your opinion, Stefan, about triplet combinations in these patients.
So the results that has been presented at the last ASH are quite convincing. There's a large number of patients included in the trial. The safety profile of the triplet combination is very interesting, probably due to ventilation not too high, and again, the effect of IVO in terms of reconstitution, quick reconstitution. So therefore, it's very well tolerated. And the overall response rate is crazy good, especially for elderly patients. So in general, that is an option that will be tested soon in one European trial. And it may be a breakthrough because not only the overall response rate could be improved versus IVO-AZA, but also the overall survival in the end could be better. So that's very appealing.
Yeah, I mean, these data are indeed very impressive, and I think they have been published very recently in
JCO, yeah.
And
it's a Courtney DiNardo, the first author, but
exactly.
Miss Marvin Peake is the second one, yes, in the publication.
However, I think we need to be cautious with the interpretation of the data because they're coming from a single center, It's a single-arm study. And I think it is important to mention that the median age of the patients in this study was significantly lower than in the Agile study. But as you said, I mean, we need to confirm this data in a randomized trial that is already activated and ongoing, combining AZA-IWO and randomizing for placebo versus venetoclax. So I think we should also discuss if our case would have been an AML coming from an MPN and post-MPN AML, and would this have changed our treatment strategy here? And I think, Stefan, you have already performed some studies on the outcome of patients with post-MPN AML with IDH1 mutation, and maybe you can give us some information on this study.
Yeah, quickly, the post-MPN AML are, generally speaking, excluded from trials. These patients were included in the phase 2 trial with the registration trial for olutasidenib. And we observed that 15 patients had an MPN. So they fell to intensive chemo, which is usually the case, HMA, obviously, and different type of treatments. The response rate was really very good, provided that oncogenic event is IDH1. These are not monogenic diseases. Therefore, the response rate cannot be, as in APL, 100% of response. So in that case, it's fairly high. Median duration is something never seen in that case.
So maybe we should sum up the most important points that we have discussed. And I would like to start with Stefan and then hand over to Gail. And maybe there's something I can add at the end. So summing up the most important aspects that we talked today. Stefan,
Very
would you
briefly,
Yeah.
very briefly, as usual, you need to have the right diagnosis, and incorporating molecular biology is crucial, especially in the elderly population. We've seen that if you have a targeted therapy, especially for IDH1 in that case, you may expect a strong improvement in terms of overall survival, response rate, overall survival, which are associated with better quality of life and better tolerability of these treatments.
Gail, anything to add?
I think things are looking up for these patients. I would add that we didn't spend a lot of time on one area to think about, which is the post-remission management of these patients. These regimens that we have discussed are predicated currently on ongoing therapy. So it's important to not just get into remission and run away. These patients do require ongoing therapy, which needs to be carefully curated if you're doing a triplet. So watch how you're doing ongoing triplets in the post-remission setting. But I think that patients should be reminded and encouraged to stick with what we know from the data, and that includes for the IVO-AZA treated patients ongoing treatment, and to also not be seduced by the prospect of molecular monitoring of IDH1 in remission as a way to stop treatment yet, because we do not know that that is the right thing to do. And I would caution against getting back a test that shows an undetectable IDH1 and stopping the treatment, which I'm hearing more of, and I'm worried about that because I think we don't have the data to support that.
Yeah. This is a very important aspect, and I think there's a lot of more work to do for us in the future. But overall, I think this is impressive data, and 10 years ago, nobody would have talked about treating patients, older patients, and also unfit patients with combinations that result in such a good outcome. I think we are moving forward. And AML is a disease of the older patient. So I think this is very encouraging data. And I thank you very much for this fruitful and constructive discussion.
Thank you for listening. Remember to download the slides and practice aids and complete the post test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Servier. To access all materials for this activity, visit peerview.com/NJR860.